Welcome to the Institute of Medicine of Chicago. My name is Pat Merriweather Argus, and I'm a member of the Board of Governors of the Institute of Medicine at Chicago and co-chair of the IOMC Program Committee. In addition, I'm the Executive Director of Project Patient Care. It is my pleasure to welcome you today to discuss the intersection of education, namely higher education, and community engagement with Rosalind Franklin University. We are going to discuss how initiating an interprofessional movement has changed RFU and how it led to a vision of establishing a vision for interprofessional education and collaborative practice. It is viewed as an essential element to improve health and wellness, patient and professional satisfaction, and the delivery of safe patient care. These initiatives created a positive impact when collaborating with communities. It provides unique opportunities for interprofessionals to work together to achieve better well-being and healthcare equity. IOMC is deeply committed to addressing the social determinants of health and achieving health equity for all. Also, we are carefully looking at the future healthcare workforce, its needs and deficiencies. There are expected shortages of doctors and nurses in the future. And for this reason, we are pleased to see the Senate committee approved a plan to diversify the healthcare workforce recently. The bill creates a framework to support student loan payment and scholarship programs that prioritize those from underserved communities entering the healthcare field. This is very exciting news and gives more opportunities for individuals who may not have considered a career in healthcare. Today's healthcare speakers are experts with long-term experience in healthcare and various backgrounds. We are delighted to host the outstanding RFU faculty today. This is the first session of a 4-session series that will be held throughout the month of April. Today's agenda includes a panel discussion, question and answer period, and updates on the future programs and speakers. We warmly welcome Dr. Wendy Rowe, President and CEO of Rosalind Franklin University. Also, Dr. James Carlson as the moderator for today's session. Dr. Carlson is the Vice President for Interprofessional Education and Simulation at Rosalind Franklin University and is an Associate Professor in the College of Health Professions and College of Medicine. Joining him today is Dr. Sarah Garber, Professor and Director of Interprofessional Studies in the College of Pharmacy at Rosalind Franklin University, and Dr. Bob Entine, Associate Vice President for Academic and Faculty Affairs at Rosalind Franklin University. And that completes our presentation panel. Quite an audacious panel that we have today. This program is accredited by Rush University and affiliated associations. You will be able to obtain your continuing education credit at the end of the program. Our speakers have completed their conflict of financial disclosures, and this information is on file. On behalf of the Board of Governors, it is my pleasure to warmly welcome everyone today. We are honored with your overall support of IOMC. If you are visiting us for the first time, we do conduct monthly virtual sessions, except during the summer months of July and August. There are numerous opportunities to be engaged with IOMC. In the fall, we expect to begin our work groups. Please stay tuned for that information. As a board member, I can confidently attest that IOMC's mission is strong, and we are confident in our efforts as we go forward. We are celebrating our 106th year, and in June, we will have reached our 107th year as an organization. IOMC is an independent, not-for-profit organization of distinguished leaders in the health field who collaborate to improve the health of the public. We are proud to draw upon the diverse membership and other regional leaders to address critical health issues. In addition to today's session, additional complimentary sessions will be held on April 8th, 22nd, and 29th. Also on May 6th, we are addressing chronic kidney disease and its disparities. In June, IOMC will hold its 2022 annual meeting and IOMC Healthcare Awards. The 2022 IOMC Healthcare Awards are open for nominations now. There are 7 award opportunities. The deadlines are May 2 to 4 for specific award types. Please consider nominating a colleague or an organization this year. The awards will be presented at the annual meeting. At this time, I will introduce you to Dr. James Carlson, who will moderate this upcoming presentation. Dr. Carlson is the Vice President for Interprofessional Education and Simulation of Rosalind Franklin University and an Associate Professor in the College of Health Professions and College of Medicine. In this role, he oversees all simulation-based activities at the university, the DeWitt C. Baldwin Institute for Interprofessional Education, and the Clinical Anatomy Labs. He received his PhD in Interprofessional Healthcare Studies from RFU, Rosalind Franklin University, in 2012, and his Master's of Science degree in Physician Assistant Practice from RFU in 2001. Dr. Carlson also teaches in a number of university programs and is a member of the RFU Masters Teachers Guild. His research interests focus on diagnostic reasoning behaviors, simulation-based performance assessment, the role of simulation in team training, and interprofessional education. As of May 2017, the RFU Department of Healthcare Simulation has been awarded accreditation by the Society for Simulation in Healthcare. This accreditation places RFU in a top tier of simulation programming, both nationally and internationally. Dr. Carlson, welcome, and thank you for being with us today.
Thank you very much, Pat. I appreciate the introduction and the introduction of our panelists today. So it's our pleasure to, I think, talk a little bit about the Rosalind Franklin experience over the past 2 decades of really focusing on interprofessional education as a framework that we use to train and educate our providers that we graduate. It's really in the fabric of what we do, and we're very excited to tell that story. It's a story a little bit about how we've built an internal culture that's focused on this important aspect of education and how that is impacting the community that we serve. Deb, could you go to the next slide, please? So our objectives for this session are to talk about the following. We'll identify important outcomes and processes to consider when building a culture of interprofessionalism and collaboration within an academic health setting. Explore the impact of interprofessional education and collaboration on the future healthcare workforce and communities that they serve. And then describe future trends in healthcare delivery and models of interprofessional education. And a little bit of background with regards to Rosalind Franklin as a university. We're a graduate level health sciences university. So all of our programs and all of our students are focused in healthcare to various degrees, whether it's pharmacy, medicine, nursing, other health professions, and including health administration and focus on areas such as population health. Whatever the program that we have, we really try to instill interprofessional attributes within that program, right? And really look at those competencies. So I'm really blessed to be joined by my colleagues. So Wendy Rowe, who you introduced earlier, is the president and CEO of Rosalind Franklin University. Sarah Garber, who is a colleague for many years that I'm always impressed with her knowledge and focus on interprofessionalism. She's a professor and director of interprofessional studies in the College of Pharmacy at Rosalind Franklin University. And then Bob Intine, who is our associate vice president for academic and faculty affairs at Rosalind Franklin University. And as such, intersects with everything from our accreditation needs to how we train and set up all of the educational infrastructure, and then how we also train and develop our faculty. So Deb, could you move to the next slide? What we're going to do is break this panel discussion into 3 segments. And we're going to start a little bit by talking about sort of how we established a vision for interprofessional education and collaborative practice. So over the past 2 decades, we have been very focused on this aspect of our mission. We thought we'd talk a little bit about why, right? And sort of what we did in terms of putting together an infrastructure to focus on that. So I'm going to open this up to the panel and starting with 3 questions. So we'll start with the first one. Why does interprofessionalism matter? And why did RFU choose to incorporate interprofessionalism into the mission and vision of the university? So I'm wondering if Dr. Rowe, you were highly involved in the early days of developing our programming around this. I'm wondering if you might kick off the discussion with an answer to that question.
Absolutely. Thank you. And I'm very happy to be here. Welcome, everyone. We identified interprofessionalism as something that was very important as a core curricular value, and we integrated in our mission and vision. And why did we do that? Well, during that time, there was a lot of talk about medical errors. For example, in 1999, the Institute of Medicine report came out, "To Err is Human," and it talked about multiple people dying because of preventable medical errors. That was followed 2 years later by the IOM study, Crossing the Quality Chasm, and it called for better team collaboration as part of their recommendations. And we took that to heart and we discussed it as a leadership team. And we put that into our mission and vision, as I said. We made it a part of our strategic plan. We made it a priority and we funded it. And I think that's really important because in order for it to become part of the internal community and part of our culture, we had to make sure that it was part of the strategic plan, and we put money up to make sure that it could be done. And then we started the development at the grassroots level. For example, starting with a course called the First Year Experience, which all health professional students took together, and had part of it had a service learning component where our students went out into the community and worked in interprofessional teams.
So Deborah, could you maybe advance the slide for us as Dr. Rowe had started bringing up some of the things that we put in place. So the timeline that you see in front of you articulates sort of our journey over the past 20 years. And early on, as Dr. Rowe was talking about that vision and buy-in, and then specific additional actions that we've taken since then. So I'm wondering, Dr. Rowe, what and actually opening up to Sarah and Bob as well, if you'd like, what were some of the actions that you see as being very pivotal? You mentioned that first year experience, you mentioned service learning, but really pivotal to establishing that strong foundation in interprofessionalism early on as we were developing a focus on this.
I'll start a little bit. We needed to have champions. That was really important. So in each of the programs, we needed to have people that really understood interprofessionalism. We had to educate our faculty, send them to courses, make sure they understood what it was all about. We also established our own competencies at that time. I think one of the most difficult things we had to do was get everybody on the same calendar, because in order for them to share coursework and to have courses together and have the first year experience, they all had to be on the same calendar. And that was something that was probably the toughest to do, believe it or not. Some of these process things can be that way. And as I said, that first year experience was pivotal in getting us started. And the students knew that they were part of something innovative and something different. And they had a lot of fun with it at the beginning because they really were feeling like pioneers. And we wanted them to go out and be change agents in the systems that they would join. And so that was important for us to make sure that we had buy-in from our students as well as our faculty and our staff.
Agreed. Sarah, Bob, anything you would want to add to that in terms of looking at that initial framework and establishing sort of that foundation that we started to build on?
I can add one thing. Development of the faculty, it was very important because without faculty buy-in, this wasn't going to go anywhere. One of the challenges within just our general system is making sure that faculty time was worthwhile. So working with the chairs and the deans to have people realize that the workload of a faculty included any interprofessional activities. They were not over and above, but they were part of the package that a faculty would put together for tenure and promotion. Those kinds of cultural changes at that level were exceptionally important for the buy-in of this entire mission of the university.
Part of the challenge, the initial challenges, I believe, were also in trying to sort of retrofit, some of the IP education competencies into programs that were already established and were full-blown programs. And so to find the time within curriculum to some degree was a challenge to some degree. But it is also an opportunity for us now, because when we build new programs now, we get to develop them with the interprofessionalism from the ground up.
Yeah, I think that's a great point. I think, yeah, when I recall that period of time too, yeah, I think, Bob, you hit the nail on the head there too, is that our curricula, and I think if you talk to any educator out there, it's packed, right? There's already plenty to do, right? So I think what I really appreciate was there was sort of, I think, a top-down and grassroots initiative going on, and that leadership had put a priority on this. Leadership to the point of making sure that time was carved out in the calendar, and sort of really focused and said every first-year student must have space in their time on Wednesday afternoons, for example, to get together with colleagues from other professions and learn, right? And then I think that the grassroots initiatives around that, they found the faculty buy-in, the development found ways to make sure that it was meaningfully engaged in the curriculum. And I think it was a really good exercise as a community for us to go through sort of that discussion, right? And how this is important, right? We agreed on that, but then the challenge was, how do we make that work within an already packed curriculum, and at least carving out that time and creating the opportunity for faculty and students to get together helped us take those first steps, right? So, all right, well, I think I'd like to move on to maybe the next segment of questions. So I'm wondering, Deb, could you advance the slide? And so I think this is a good time to talk about, those are those initial foundations, and you saw a timeline on that we had put up there, but we've since that time obviously taken a number of steps to really try to build the culture internally, and then also allow that culture to spill into our community in the way we serve it, over then subsequent years and up to today. So I guess I would start with this question. How was the interprofessional culture then built? So once we laid that framework, how did you really build culture? It didn't happen overnight, right? And then what programs specifically did we put in place? And Deb, if you could advance to the next slide, I think that will be a good visual to help us. Sarah, do you want to maybe pick up with that?
I can start. I'll start up at the top of the circle there with university structures and governance. It actually turned out, when we took a look at it, that we have a very strong tradition and culture of shared governance. And because of that, our governance structures were already essentially interprofessional. They spanned all of the programs across the university, at least in the faculty senate, but also the staff governance body was also across the university. So by pulling those into an aspect of, our interprofessional culture, it set the stage. Our student governance is also pan-university. So all of our student governance activities include all of the programs. So that was exceptionally helpful to realize that, gee, we've already started this. We already have an aspect of the culture building blocks that we need. Then moving into the academic programming, we realized several things. One is that we needed an academic home. So we built a department in the College of Health Professions that was interprofessional healthcare studies. And that gives any courses like our first year experience course an academic home, which is in an institution very important. In addition, we also realized that although each individual program have their own curriculum committees and each program needs to maintain autonomy within their curriculum, we needed a body to be able to talk about curriculum across the university and how the individual programmatic curriculums work together in an interprofessional fashion. So we developed the Interprofessional Academic Committee, which is a committee composed of the representatives of each individual programmatic committee, and works on a variety of issues, including registering of courses. How do you number them? How do you maintain them? What's the content? In terms of electives and things like that, how do you develop courses? What resources are needed? So those types of things really helped build the culture and also allowed our faculty and staff and administration to start working together towards a common goal. Bob, do you want to take the accreditation and HLC project?
Our regional institutional accrediting body is the Higher Learning Commission, and programs that are on the open pathway for HLC accreditation are required to identify and develop a quality initiative project. And prior to our last site visit, which occurred in 2018, that quality initiative project that we did was focused on interprofessionalism. And through the work of that project, there was 14 recommendations that resulted from it, which were designed to stimulate and continue our growth in interprofessional practice and education at the university. And we have implemented basically those 14 recommendations. Interprofessionalism is becoming more and more a component of accreditations across the country, and we routinely receive commendations for our interprofessional mission and how we have implemented it at the university. And not only from HLC, our regional accreditor, but we also have many accreditations, specialized accreditations for the programs that our healthcare programs that have that specialized accreditation. Now, the Interprofessional Community Clinic is, I believe, will be talked a little bit more in some of the other sessions that are going to occur later this month, but briefly, it is a clinic that is student organized and led, and it's a free clinic for the community, and that is immediately adjacent to the RFUMS main campus. And by design, the students and faculty mentors who treat the patients are in interprofessional teams, which gives the students an opportunity to engage with the community within that interprofessional environment almost as soon as they come to campus, because first-year students can volunteer at that clinic as well.
Yeah, I agree. I think thank you, Bob. The Interprofessional Community Clinic, I think it will be in a future session. I think in 2 weeks, there'll be a little bit of discussion around that in more detail, but it's an excellent example of, I think, once we had established that IP mission within our university, the students simultaneously or along the way were also really interested in outreach to our community and serving patients. And when they came to us to say we would like to start this free clinic, it was never even a question as to whether or not it would be interprofessional. It wasn't one organization, or one of the colleges or programs that was starting it. It was the students across program that said, we want to do this because we feel we can do this well together, right? And I think that's a really powerful example of how laying that internal community framework around interprofessionalism is able to then spill into the larger community and bring the benefit of that collaborative practice to the people we serve outside of our walls, right? So that's been I think a fantastic example. So I can't wait actually for a couple of weeks when we talk a little more in detail on that. I think it also goes with saying too that the service learning component that really is at the heart of what the ICC does, or the Interprofessional Community Clinic does. It's service to our neighbors, but service learning also was and continues to be an important part of our interprofessional framework as well. For example, early on in our Foundations of Interprofessional Practice course that students took, one of their projects was to work through a service project in the community. It didn't need to be clinical. It was, what was the community need and how can we serve that? And then their challenge as a team was to come together as a group, identify how to meet that need, and then deliver that service project. What that did for us, right, is it created a very robust network, I think, with our community partners, right, of where need was in our backyard. And that's led to student organizations now that are committed to providing that service. We have an orientation. So during orientation of our programs, the first day when they come on campus is to do service learning together as part of their orientation. Why? It's to get to know the communities that they're serving and one another at the same time. So I think that's a very powerful example. Before we move on to the next slide, is there anybody want to add anything more to the discussion thus far from the panel?
I just wanted to note that IP scholarship and research, this is we have a Baldwin Institute, which is an interprofessional institute. And one of its main components is the promotion of scholarship and research. And this is a really fertile aspect of faculty development. And we find as we keep on looking throughout the university that faculty are collaborating and working with each other more and more. So the more we learn about each other, the more we do it. And I think on a subsequent slide, we'll talk a little bit more about the student distinction for excellence in IP and healthcare.
All right, so Deb, could you advance to the next slide, please? So Sarah, you had, oh, I'm sorry, go ahead, Wendy, please.
Yeah, no, I also want to say, just as we talk about interprofessional practice and its effect on morale of the clinicians, IP education in the academic environment, I think really improves the morale of the teachers, the educators. And I think that's kind of what Sarah was getting at too, that people enjoy, they get to know what another profession does, they get to work with them, there's excitement, there's innovation. Because, you know, you always hear that collaboration enhances innovation or leads to innovation. And I think that morale and the collaboration really does lead to some really interesting innovative courses and innovative ways of looking at practice and education.
Right, and so I agree, and I think that's a great actually opportunity to talk a little bit about the DeWitt Baldwin Institute. So those of you who are familiar with DeWitt C. Baldwin, he may know that he actually passed earlier this year, but is widely regarded, his work is widely regarded as really the foundation of modern interprofessional healthcare education and the way that we train students and really highlighting the importance of it. And so when we developed, we were really wanting to develop that place, as Wendy was talking about, for faculty to come together to be able to coordinate and collaborate around ideas, whether it's research or education. We had a discussion about, should we develop kind of an interprofessional college, or do we want to make sort of an institute? And we actually chose the institute because colleges, you know, they have their focus on the professional development of their graduates within a specific profession, right? But an institute was a place where we felt like folks could come together to share some of these ideas outside of that college structure and really be able to have a place to advance topics that were of shared interest. So I think one of the most pivotal things in terms of the development of that was to really give faculty a space, give students a space and place where this could sort of, as an institute, thrive, right? And look forward to the future. So I just wanted to point that out, that I think that's been, it's not all things IP to our university because it's part of our mission, but it's a place where these things can incubate, right? And then sort of be advanced in an organized way. Could you go, Deb, to the next slide, please? This is just what, as Bob, you were referring to, our QI project for the Higher Learning Commission, where we really were trying to build that around. You see the 4 IP objectives around there from the IPEC competencies. So teams and teamwork, values and ethics, roles and responsibilities, and interprofessional communication being a fabric. That we had 14 recommendations that we are working on as a quality improvement project. So as Bob was talking about, and then Deb, one more slide. Bob, do you want to talk a little bit about what we've learned through that process, some evidence of success, and what we have learned? Maybe back one more, Deb. Actually, go back 1 or 2 more slides. There you go. Go forward 1 more. Perfect. All right. Bob, did you want to talk a little bit about the academic outcomes and evidence of success?
Sure, I can definitely talk about that. So from historically, I mean, as we're developing this interprofessional model for the university, we've performed several evaluations over the years to kind of gauge where we are in both our cultural development as well as our IP education. And that's come through mostly through survey data. But very recently, we just finished a very deep assessment and looking at all areas of the university. And what the results of that, what came out from that, it was the results very clearly indicated that as an institution, we function as a very highly integrated interprofessional community. And that's illustrated through many aspects, but illustrated through our administration as well as our governance structures that we have at the university. So then from an educational perspective, what we saw was that 58% of the Rosalind Franklin course offerings teach to at least one, and usually more than one, and very often all of the competencies. And very importantly, very important aspect of this, of course, is that the students are also assessed on their competency development as they are in those courses. And then when we took those 58 courses and we mapped them to the various curricula, it also became very clear that there has been an intentional scaffolding of the IP courses throughout the curricula, which results in a continuum of competency development and application through the students' educational experiences. And so as Jim had already mentioned, when their students first come in, that we have that day of service that actually precedes our actual formal orientation. Then throughout the students' whole curriculum experience, they're continuing to develop, be exposed to, and apply those competencies. And then the very last event we have our students have with us is our interprofessional commencement. And so right from the very beginning, throughout their whole educational experience, right to the end, the students are immersed within that interprofessional environment.
And I think we've touched on some of this, but other outcomes and some evidence, we've systematically engaged faculty and staff onboarding. That includes an interprofessional framework and exposure to that sort of method of teaching, right, or that method of engaging students. As Sarah had mentioned earlier, workload assignment and evaluation of faculty have interprofessional elements to it. And what's really, I think, exciting to see is the students and student organizations and co-curricular activities have just by design taken off in many, if not, well, I'd say the majority of them have an interprofessional framework to them. So I think across the board, whether it's curricular, governance, faculty, staff, students, and whatever work folks are engaged in, this is an important element to what we do day to day. Next slide. Sarah has been passionately working on a distinction for interprofessionalism. So there's an additional way we can recognize this. So Sarah, I'm wondering if you might talk a little bit about this that we're rolling out this year.
Sure. This is a program to complement the scaffolding that goes on for the IP competencies within an individual program. But as we realized, putting the competencies into the programs and curricula wasn't quite sufficient. We wanted something more to offer our students, especially the students who wanted to go above and beyond and really show their commitment to the IP philosophy in professional practice. So this is a program where we have faculty mentoring students, and the students develop their own projects, and we encourage them to be as creative as possible. And they have to choose one of the 6 areas, 3 of the 6 areas, excuse me, to do these projects in. And they have the duration of their tenure at Rosalind Franklin to complete them. The students develop a portfolio and are evaluated on that portfolio. The additional aspect of this program is that not only does it help students excel, but it also helps develop our faculty and have our faculty show their expertise and involvement in the IP activities around campus. And it encourages more collaboration across the university at all levels. So it's really kind of just a fun, wonderful program to have and complement our culture.
Right. And something that I think students can take with them. They don't have to do all 6 of those areas you see in the diagram here, but 3 of the 6 as it fits what their future plans are, right? And skill sets that they like to develop as they view how their career will unfold in patient care. Next slide, please. All right, so I wanted to move us on to sort of the final phase of our panel discussion, and we've looked at how we started and kind of where we've been over the past 2 decades and different actions and programs we've put in place. But I think it's worth some time to look at the future, right? So 20 years after some of the studies that Dr. Rowe had referenced at the beginning, crossing the quality chasm, into error is human. And our deduction 20 years ago that IP would be something we wanted to focus on. As we look ahead and today, does an IP focus continue to be relevant to healthcare delivery and patient care? And I'd like to open that up. Maybe Dr. Rowe, since you started us off with why we start, the discussion as to why we started this. As of today, does this still hold true?
Absolutely. I think it's even more important. We're talking a lot about burnout of our clinicians. We know that there are shortages of nursing. Nurses are leaving the field because of other opportunities, but also because of burnout. And we talk a lot about resilience. We talk now about the quadruple aim of care, not the triple aim. So we know that there's evidence that working collaboratively, working in an interprofessional team does improve morale. People are happier. And I think that this is one way that we can continue that. And it also leads to innovation. We need innovation. Innovation in our healthcare system. The pandemic has shown us a number of things, one of which that we need to do some work on our healthcare system. And we want to train our students to be innovators. And working collaboratively, we hope that they can solve some of the problems that we have going forward.
Yep, I agree. And I think the past couple of years, especially that innovation component, the common one that we've discussed these days is how long and to what degree will telemedicine, telehealth as a delivery mechanism stick, right? And I don't think we're going back to pre-pandemic levels of very, very light usage, but maybe it won't be the same. But I wonder with the digital transformation of the way healthcare is provided, the hospital at home, right? Concepts, the way we can connect via, as we are now, Zoom, experts, providers that don't have to be in the same facility at the same time. What does that do to the roles and responsibilities of different healthcare providers, right? The technical training that they need to have to thrive on a team, right? So those are the things I think that are the next steps, at least for us as an educational organization to tackle. And then also with regards to community, how do our patients then receive care? And what are some of the challenges associated with that, either in a tele, and of course, the social determinants of health come to mind, and thinking about your access. Can these tools help access? Does it create additional barriers if you have less access to technology? I think there's a lot to think about and a lot of solutions the team can pose, but it will change rapidly the way probably we need to change or educate our students. So I think, Deb, could you move to one more, this next slide? So as Dr. Rowe was referencing, sort of our model, and you talked a little bit, Dr. Rowe, about the quadruple aim and thinking about population and patient health satisfaction, reducing costs, improving resiliency in the teams, as you mentioned. We really view those as obviously outcomes at any system. And for us, the quadruple aim of higher ed, how well are students learning, right? What's our student satisfaction? How can we reduce cost and improve student morale and resiliency? We view IP as a process. It's the way we do our work. We're achieving those items on the right side, and that's what we're striving to do, to work toward as outcomes. And we view the IP process as a pivotal way to do or to achieve those outcomes in a better way, right? In maybe a more effective way. And so we keep focusing on those areas, and we look for students that bring these attributes in with them. In our admissions process, we try to refine and cultivate these skills during their time with us. And what we really hope, I think, too, is that they will be change agents. We routinely hear from our students, hey, I know you teach us some of these things, but I don't always see it practiced that way. And we say, that's okay, right? Different organizations do things in different ways, but you're forming how you're going to practice, right? You're forming your workflow and how you collaborate with others. And you will be the change agents over time, right? That bring these things to your systems or profession. So we look very, very positively at the future, I think, with regards to interprofessionalism being a core attribute of how we will be successful. Before we move on to maybe some group questions, is there anything else the panel would like to add on this sort of final phase of, is IP still relevant? And as we look ahead, what do we see?
When I look at some of the things that we've learned from the pandemic, we've learned that there's this kind of disconnect between public health and our conventional healthcare system. And I think that's something that needs to be solved. And it's something that involves all health professionals, and something that could be solved collaboratively, and some very innovative solutions could come into play. We also learned from the pandemic the importance of prior health and the importance of lifestyle in terms of mortality and morbidity. And that's also something that is interprofessional in nature, can be taught interprofessionally, can be looked at in terms of systems to lifestyle medicine. So I think the curricular components that we need going forward really speak to interprofessionalism.
Any other commentary from the panelists? Otherwise, I would say, Deb, we can move to the next slide and open maybe up for a group discussion. I saw one in the chat that I think we could start with, at least, though. Bethany Robertson had asked, do you have any longitudinal data on the health professionals' practice as a result of being part of this curriculum and culture? That's a great question. Of course, that's the hard one to get, right? And what I'd say, here's how I'd answer that question. We've focused really on relying on the fact that the data out there shows that if you function on if you're on a high functioning team, resiliency is better. You may have better outcomes. And we've focused on our process metrics and process outcomes in terms of how, is our interprofessional process working as intended, right? And I think we have ample evidence it's well embedded in our culture. It's well embedded in our curriculum. But then after our students leave, one of the challenges is getting after exactly what you're asking about, Bethany. And some of the metrics that do exist out there, our alumni surveys are opinion-based, but and they say that this has been positive in the way it's shaped practice. In terms of accreditor, some professions will evaluate all graduates of a specific profession, like I believe pharmacy does that. PA has done that. The GQ survey in medicine does that. And routinely, we do see that our students are reported as this area of interprofessional engagement and collaborative practice is quite strong amongst our graduates. We do get that information and feedback back. So that's the level of data that we have thus far. But I think we're constantly looking for ways to do exactly what you're saying with that longitudinal, but it's challenging to do for sure. We're always open for ideas. So.
Yeah, employer surveys, student satisfaction surveys, that kind of indicate that our students rated that they feel like they're doing it, and there's high component in the curriculum. And then employer surveys, which are difficult to get, they will also say that they work really well as a team.
I'd say to the group too, are there the other questions maybe to put in the Q&A or the chat for the panel? I put a few on here to think about or maybe reflect on as you think about your own institution, is how relevant do you view IP to the culture and those you serve, right? What changes do you foresee in your institution where an IP focus might impact the work that you do? Or how will you measure your success, as Bethany was just bringing up?
I can make a little bit of a comment on how to measure success. One of the things that we've done recently is not ask people, gee, in your curricular or whatever, how IP are you, but how do you address the competencies of IP? So sometimes breaking it down to the competency level can make the assessment much more accessible to people.
I agree. And I think there also are a growing number of tools out there available. Like, for example, AHRQ just released, I think it was last week, a toolkit around team steps, but for diagnosis. So diagnosis continues to be, undesirable diagnostic events tend to still be out there, right? The stats show that one of us, or many of us will engage or have experience with an undesirable diagnostic event or error. And more team working around that, around different professions, is being looked at as a potential solution. And like I said, AHRQ just released a wonderful module on using team steps applied to diagnosis, which, and there's more of them also at their website as well. I see another Q&A here, or in the chat. Sevam has asked, how do you involve the community, especially your community partners, in the IP program? Great question, and I'm glad you asked that. Would one of the panel like to pick up with that? I mean, I can get started if you want. So there will be a future session that talks a little bit more about partnerships, but what I can say in terms of what comes to mind to answer your question is, we have two kinds of partners, generally academic partners, and then our clinical or community partners, right? Or actually, and each of them have their own, I think, interest in IP or in their relationship with our university. We try to include deliberately multiple professions in those relationships, right? So for example, with our local community partners, in terms of, just in the area of North Chicago, north of us are schools, right? So just outreach to some of the schools, and we have some exceptional programs at the grade school and high school level to engage students in science, right? Through a program we call Inspire, or through Science Saturdays. And those are not done by one program alone. They're really engaged by a variety of professions. Because, those students, I think, as they look ahead, they may know what a doctor is, they may know what a nurse is, but maybe they've never seen a physical therapist, or maybe they've never engaged other professions that they might find a passion for, right? And so by doing it interprofessionally, one, we're helping to create, I think, positive opportunities for those students, but also exposing them to role models and professions that they may not have even never considered before. So that's one example, right? Others that the community might share, or the panel might share?
I think another example is that in the first orientation that the students have, they do a day of service, and that's all out in the community. That's any number of things. It can be the local women's shelters or family health fairs, etc. So there's a lot of establishment early on of community service. And then a number of our co-curricular activities and groups are very involved in any number of aspects of community activities and community agents. So there's a lot of community activity and community service that goes on beyond the specific curriculum and program.
Yeah, and the interprofessional community clinic that we've previously discussed is another example of how our students and we engage with our community, but we also have our mobile community care coach that again is when that care coach goes out and goes out into the community. It is typically interprofessional. The students that are on board, as well as the mentors that are on board, are interprofessional as well. So again, bringing an interprofessional team out into the community, specifically for treating individuals, et cetera, that can't make that can't are not mobile enough to be able to come to the university clinic.
Yes, we're going to talk about that in a future session. The care coach and the ICC, you'll hear more about that. But our ICC has been very successful during COVID in providing vaccines to the Black and Brown population around the university, and also COVID testing and vaccines, and also providing education to people. And there were many people that got vaccines that were very hesitant to get them in the first place, but after education and talking to students and clinicians, they took the vaccines. We're very proud of that, but that's one of them. We're also connected with our health department. We have a free podiatric medicine clinic at the local health department, the Lake County Health Department. That's the first time they've offered those particular services to clients there. So
Pat, looks like you had asked a question about, do you get feedback from the provider locations, hospitals, on the IP students that are practicing at facilities? Do students ever comment on their applications of IP when they work in hospitals or other settings? Do they feel supported for their IP focus and practice? I guess in a nutshell, I would say the evidence I see is yes. They're definitely, our students are evaluated, let's just take that for example, on their ability to work with others, not just sort of in those foundational clinical courses, but as they get into their, foundational didactic courses, but when they get into their clinical rotations, for example, many of those include 360 evaluations and feedback on how well they interact with other members of the team. I'd say also our alumni and our graduates come back and say, yeah, maybe they didn't realize it at the time, but the lessons that they learned around collaborative care, how to work with others, is something that they find very valuable in either their residency programs or beyond, or wherever their next step is after they leave us. We get those comments back very frequently where they didn't even realize it at the time as a student, but now that they've been in practice, the aha moment kind of kicks in, right? And how important their relationships and collaborative practice are.
Well, thank you. Again, I think this discussion was outstanding today. And I just really, from the beginning, you have modeled, the foundation which you established in terms of the IP, the faculty engagement and involvement, and coming, like you said, from the grassroots also, and in just structuring a program so that it can be successful. And you really modeled the way of working interprofessionally within your organization. And that really has built a wonderful foundation for going ahead and then also having the students follow what's being modeled. So congratulations, this is very exciting. And as you mentioned, you know, telehealth, telemedicine, hospitals at home, those issues I have a strong sense you'll be able to address as well. And, you know, the one thing too that really struck a chord for me was also on the Institute of Medicine, you know, the errors that were being occurred in hospital settings, and oftentimes because of lack of discussion and communication. We've said for many years, communication was one of the biggest challenges we had in healthcare. And again, you're working to address that and have successfully addressed it. So thank you. I really want to thank everyone for the presentations today, for their thoughtful discussions and sharing their successful experiences, because this is a model that we know is here to stay and has proven to be successful. We want to remind everyone of the IOMC Healthcare Awards. The closing deadline is May 4th for all submittals. And please see the IOMC website for more information. Thank you for attending today's discussion. We hope to see you on April 8th for the next discussion on the intersection of education and engagement. And this is going to be very exciting too, because we're going to be focused on addressing health equity through community engagement, education, outreach, and partnerships. So with that, I would like to say, everyone, follow us on LinkedIn, check out our blog, and visit the IOMC website for more details. And thank you all. Thank you, presenters, for a wonderful session. And again, very insightful and a way forward for us in healthcare. Have a great day and a great weekend. Thank you.
Thank you.
Thank you.
You too. Thank you very much.
Thank you.
Thank you.